So, what we are learning real time is that insurance companies like Cigna have a relationship with a repricing company called Multiplan, and that as a result, the repricing company gets part of the money that is due for the office visit from the person that's paying for the insurance. The insurance company gets part of the money for the visit for administering the insurance. And then the facility or provider gets a part of the money.
Welcome to UpMed, a journal of healthcare's race to the bottom, hosted by Dr. Erica Urquhart. Join Dr. Erica and her guests as they pull back the curtain and share a behind-the-scenes look at the healthcare industry, all while providing solutions for better patient care and management. Now, here's your host, Dr. Erica.
Hello, welcome to our listeners. You are listening to yet another episode of UpMed, the Journal of Healthcare's Race to the Bottom. I am your host, Dr. Erica Rowe Urquhart, and I'm so happy to be in the room with you today. This episode is going to focus on that analogy that I made in our very first welcome episode. The analogy of healthcare as it could be related to your cup of Starbucks coffee. Healthcare and Starbucks? Are we talking about too much caffeine? No. No, what we're talking about is the idea that in any interaction in a capitalist society such as ours, there is a monetary value that is placed upon services that are provided. And in general, that monetary value is discrete and quantifiable. So, when you approach your Starbucks franchise, in general, if you are in a specific region, your latte will cost the same no matter which franchise you go to. And not only that, you will have to pay for your latte before you can consume it. Now, there are certain issues in healthcare that preclude us from saying that we have to pay for all healthcare interactions up front. But in reality, for most healthcare interactions, the price could be quantified up front. For example, Walgreens, CVS, Amazon, they have all ventured into telehealth, telemedicine, and they all decide that the fee for these interactions with a healthcare provider, maybe not even a physician, would be offered at a certain price. And so, for example, CVS, if you want CVS telehealth, you pay $50 to $125 to speak with their healthcare provider. Now, this is where it gets quite interesting because as a medical doctor with a medical degree, residency training, and a practice, a physical location, I cannot do that. I can't do what CVS does. I can't say, in order for us to have this conversation, you need to pay me $50 to $125 upfront if I am a participating provider with an insurance company. So, what happens in most interactions where physicians are treating patients and are on the panel of an insurance company? What happens is something like this. The patients who are also on the panel of that insurance company call my office and schedule an appointment to see me. Now, when they arrive, I verify that they are in fact on the panel with the insurance company. I verify the insurance information. I may even, depending on the interaction, have to get prior authorization for a visit. But how much I'm going to get paid for that visit? Not known, unknown, undetermined, not transparent to my office staff, to me. Because depending on how that patient got that insurance, if it's an employer funded insurance plan, if it's a plan with a certain prefix of letters before the numbers on that plan, what that plan pays could be very different. So that latte that I have standardized and I'm trying to provide a certain level of quality and diligence on my part, that latte could be anywhere from $20 to $5 to $150. Nobody knows. And what's so curious about this is that we have this system where we do quantify what services are offered. So when I submit the claim to the insurance company, I'm telling them specifically what I did. I'm giving them a CPT code. A CPT code represents every interaction that I have with a patient. So this CPT code would be the equivalent of saying the patient got a latte with soy milk and extra foam. And as a result, this is what I think the amount should be. And the insurance company then decides whether or not they'll pay it. So, why am I going into all this detail about the money behind healthcare, the money behind what happens if a patient sees me in my office? There was this New York Times article that came out on April 7th. And there were actually a series of 5. And it was essentially an expose. It gave us the details behind what happens with repricing with these insurance companies. So, what we are learning real time is that insurance companies like Cigna have a relationship with a repricing company called Multiplan. And that as a result, the repricing company gets part of the money that is due for the office visit from the person that's paying for the insurance. The insurance company gets part of the money for the visit for administering the insurance. And then the facility or provider gets a part of the money. Now, you would think, in relationship to the role of all of these individuals, that there would be some parity in terms of how these numbers break down. But if we go to that New York Times article, it is fascinating. Fascinating. What we find, and these are secret documents. Yes, secret documents. What we find is that for a claim that is billed $1,995, the provider will get $134.13. The insurer, Cigna, will get $658.75. And the company that did the calculation, that did the repricing, will get $167.48. Are you kidding me? The bill was for slightly less than 2000. The insurer gets 660. The repricer gets 167.50, and the provider or the facility gets 134. Yes, that is what we are dealing with in our current system, and it's legal. So, I asked ChatGPT, what do you think? What do you think about insurance companies having stock in companies such as this, Multiplan, Optum, that do these repricing, Zealous? What do you think about it? And what are the risks of it? So, ChatGPT, what do you say? Let's read what ChatGPT had to say. Some insights into the concerns. Number one, monopoly and market control. Number two, conflicts of interest. Number three, data privacy and security, because these companies have access to vast amounts of patient data. Number four, influence on healthcare policy. Because of their significant market share and financial resources, they can exert considerable influence on health policy making. And this influence could potentially shape regulations and legislation in ways that benefit their interests, but may not necessarily align with the broader healthcare needs or public health goals. Number five, impacts on healthcare providers. This dominance could exert pressure on healthcare providers to conform to their practices or participate in networks under unfavorable terms. Now, do you see why I am chronicling healthcare's race to the bottom? We have a real time example now that is demonstrating to us the necessity to reevaluate how we go about paying for our healthcare, how we go about making this middleman, the insurance company, and now their affiliated repricing entities, accountable, and how important it is to have transparency about where their dollars go. So, my blood pressure is going up as I speak, but I want to give everyone some food for thought. Number one, are we hearing anything from legislators about this issue? Number two, are we going to see more articles, more exposés that are really giving us these numbers? Because that's all we need are the numbers. And then we'll understand that there is something very wrong here. Number three, can we ensure data privacy and security when we have these companies that no one is given permission to have access to our data, that have access to our healthcare issues, what has been billed, who has been paid, that all these ancillary companies have access to patient information? And then, lastly, can we honestly say there's no conflict of interest here? Where private equity is basically bartering on both ends, both sides. They're buying healthcare institutions and facilities. They're managing these repricing companies. And then there are significant shareholders in the insurance companies themselves. Wow. I know this needs a lot more explanation, and we're going to have to go into a lot more detail in the future. But let's just be clear. For that $1,150 episode of care, Cigna got $658, and the provider got less than the repricing company. That in and of itself is addition to an argument. Whoa, we do need some change. We're going to need an UpMed. We're going to need something because healthcare is making its race to the bottom, and it's happening quickly. So I'm going to conclude today's episode just by saying look forward to another conversation with an impressive healthcare provider in our next episode. And I wish you well. Look for that New York Times article, do your own research, and possibly join me in the conclusion that we have to do something because we're chronicling healthcare's race to the bottom. Thanks so much for joining us for UpMed, the Journal of Healthcare's Race to the Bottom.
Thank you for listening to this episode of UpMed. For more information on Dr. Erica, visit her website at upmed.us and her LinkedIn profile at Erica Rowe Urquhart. To continue the conversation, visit and subscribe to our YouTube channel. at Urquhart. And don't forget to hit the follow button on your favorite listening platform so you never miss an episode. We look forward to joining you next time on UpMed, a Journal of Healthcare's race to the bottom.